second speaker, which is Professor Gabriel Leung from the University of Hong Kong. Just as a brief introduction, Gabriel holds the chair of Public Health Medicine at the University of Hong Kong. He's the 40th Dean of Medicine there and the inaugural Helen and Francis Zimmern Professor in Population Health. He was Hong Kong's first Undersecretary for Food and Health until 2011, and while in government was the Director of the Chief Executive's Office until 2012. Gabriel is one of Asia's leading epidemiologists and global health exponents, having authored more than 500 scholarly papers. And he also led Hong Kong government's efforts against pandemic flu, H1N1, in 2009. And most recently for COVID-19, he's been an official advisor to the Hong Kong Special Administrative Region and the Chinese Central People's Governments, as well as to numerous overseas jurisdictions and international agencies, including the WHO. Gabriel, over to you.
Excellent. So I'm going to focus on the whole process of co-producing evidence with the authorities to inform policy. And I'm going to actually give a first example from the very beginning of the pandemic with mainland China, and then a very recent example of the so-called third wave in Hong Kong. So this is the first epidemiological report from Wuhan, and this is based on 425 cases, or the first 425. And of course, everybody now knows the story. I don't wish to revisit the science of it, but rather to sort of tell you a little bit about the background of how this actually came to be. So clearly, everybody knew that the news broke on New Year's Eve, or basically the last day of 2019. And then we had been in touch with our colleagues at the National CDC and various different levels of government at the provincial level, as well as at the municipal level. And we had been offering to contribute and to share our expertise. And we have heard nothing for about 3 weeks. And then on the 22nd of January, we got a call in the afternoon asking us to take the first flight out to Beijing on the 23rd. And we spent the next 36 hours in Beijing working with various different teams in the National CDC. And then 5 days after that, this appeared on the website of the New England Journal. So it was an emergency response epidemiologically to really try to get the first evidence of the very basics. What are the different delay intervals? How do the distributions look like? And we know that some of these estimates are quite frail. For example, if you actually look at panel B, it's the serial interval was based on six cases from five clusters. So we know that this is really sort of a very special situation. Nevertheless, we very much wanted to work with government to co-produce evidence to inform, for example, knowing what the incubation period distribution looks like helps you set the quarantine period. And so that's really sort of the story behind this first report. And in parallel, what we have been doing, and of course, a very similar parallel effort at Imperial at around the same time as well, was to work out, how big the Wuhan cluster really was, because we all remember that the first case or the first cluster was about 11, and then it went up to 27 or 29, then it went up to somewhere 40 plus, and then 50 plus. Everybody knew that, including the Chinese, that probably that's not the real cluster size, but very few people actually could work out what was the real cluster size. Now, it's important for a very sort of specific reason. The reason was there is a period of the largest annual migration which is called the Spring Festival Related Travel, Chunyun. And for this year, it began on January 10th, and it usually lasts 40 days. And given Wuhan is right here, by the way, it is literally the center of the entire country. So there are major transport hubs, north, south, east, and west to it. And if Wuhan actually has a sizable cluster, then given that January 10th was the beginning of the largest human migration on an annual basis, it could actually spread it all over the country. And what we did was we were helped, of course, by the exported cases that were first detected in Bangkok and in Tokyo, and then basically worked backwards to work out the likely cluster size in Wuhan, and then using mobility data on the Tencent platform, and worked out for these major cities in China, what would be the likely number of infections that you would be seeing. And that was a parallel piece of work that, in fact, was very much welcomed by the national government. And in fact, they encouraged us to make sure that this was as widely disseminated as possible. So that was yet another piece of co-production. Of course, none of it relied on proprietary or private data of the government, but it really just relied on public information. But what they were really interested in was what was the likely extent of spread. And of course, as part of that work, we were not trying to show what would be. It's not a crystal ball exercise. We were simply trying to show what could be. And therefore, what sorts of policies government should be looking at in order to reach this scenario as opposed to this scenario with no controls. And I think that the truth of the matter was it was somewhere between this scenario in the middle and then this in the right-hand column. And of course, we subsequently then went on to assess what actually happened. And this was actually done almost during the same time as the China WHO joint mission. There were 25 of us that went to 4 provinces and 6 different cities. And then that took 10 days, and then we took another 4 or 5 days to finalize the report. That gave more information to the world in the middle of February to hopefully help the rest of the world prepare for what they might face come March and subsequently. And of course, if you actually look at it, these are the major cities, Beijing, Shanghai, Shenzhen, and Wenzhou. The reason that these were picked was because they actually had very good public data, and also importantly, desegregating between local and imported cases from elsewhere. And what we were able to show were that, in fact, very quickly, because of the Wuhan lockdown, and in fact, the entire lockdown of the whole country, and the neighborhood type of interventions that were imposed, that were facilitated by online apps or platforms on the Alibaba and the Tencent apps, that's really the sort of secret source to success of very quickly bringing down the RT to very, very low levels, even amongst those places which actually did have a spike above 1 earlier on during the end of January epidemic. This is basically the top 5 affected provinces: Guangdong, Henan, Zhejiang, Hunan, and Anhui province. Very similar pictures, and these different rows, B, C, D, and E, simply are representations of different assumptions that we made. Now, another piece of work, again, that were proceeding in parallel, again, with efforts in Imperial and also the London School, was looking at this clinical severity. So this was based on, again, public Wuhan data. And in this co-production, because of the transparency and the uploading of the public domain data, we were able to work out essentially what the symptomatic CFR was. The base case was actually at 1.4, which was identical to the imperial estimate, but subsequently we revised it upwards because Wuhan actually revised upwards their death data, probably a month into their controlling their particular outbreak. What I wanted to show you is a very old slide. Actually, you will see, you recognize Azra's name here. This was a piece of work that, in fact, all three speakers worked on 17 years ago. And it really just shows you that you can't really guess what the CFR is because you would invariably get it wrong depending on the shapes and the temporal relationships between the different delay distributions. So for SARS, if you use the crude estimate, you will actually underestimate. And as the epidemic sort of proceeds, you will slowly find that it will rise from about 2-3%, which was the WHO estimate at the beginning of the SARS outbreak, to reaching 17% eventually in Hong Kong. The reverse, of course, happened with the pandemic in 2009, the flu pandemic, which I'm going to show you in the next slide. But this is actually 2013. This is 10 years from SARS. This is the H7N9 epidemic out of the Yangtze River Delta, which is the Shanghai cluster, which eventually spread to the Guangdong southern province. And if you actually had guessed that it was going to look like the SARS outbreak, it actually, in fact, was the reverse. And it's simply because of the different shapes of these delayed distributions. This is for SARS, and this is for 2013 H7N9. And this, of course, is what I had referred to just earlier on with the 2009 pandemic. Again, depending on whether you are looking at all infections, the IFR, just a symptomatic CFR, or amongst those who actually had laboratory confirmation. Now, this is really co-production. This is the first day of the Hong Kong sort of lockdown. This is our chief executive. I think her face is very well recognized now globally, but for a very different set of reasons. This is our health minister. And this is me on the first day of the Hong Kong lockdown, trying to explain to the Hong Kong population why we're doing what we're doing. This is the final press conference of the WHO China Joint Mission back in the middle of February. On the left is the leader of the Chinese team, Director Leung, who actually also was part of the SARS outbreak team back 17 years earlier. And this is Bruce Aylward representing the WHO side of the joint mission. Another piece of co-production, and in fact, Ezra and I met in Geneva back in February, just before I actually had to leave at the end of the first day to join the joint mission. And this is the R&D blueprint, where there are a dozen themes, one of which is epidemiology, and bringing the entire world's policymakers and scientists together to really work out, especially those early epidemiological information. And then working with various different countries and supranational agencies as we have gone along. Now, as I had promised, I am going to show you a very recent example of us trying to work with the Hong Kong government on controlling the so-called third wave, which is our largest wave thus far. So basically, when you talk about the real-time reproductive number, you use it to try and monitor how your interventions are doing and whether you need to layer more on or whether you could actually try to take the pedal off the accelerator and give it a little bit of a break. Just as Neil has said earlier on, those pulses of suppress and lift. So one thing that you of course have to realize, and many of us do, but so far has not been able to, on a routine basis, actually come to tackle, and that is the observed data that is as reported, the total number of new cases on a daily basis, actually they reflect past transmission events. They reflect infection events that took place probably about 10 days ago. It's because, let's say that you are infected today, on average, you take 5.5 to 6.5 days. That's your average incubation period. It takes that long for you to first show symptoms. So unless you already are under observation or medical surveillance or quarantine as a close contact of an infected case, let's say that you are a primary with an unknown infection source, there's no way that you would know that you have already been infected. So you would have to wait until symptom onset to actually make the decision of whether you're going to seek medical attention. And usually after symptom onset, most people take at least a day or two before they would actually go and seek care. Once you get there, you will hopefully get a test, either on the same day or on the next day. But depending on the testing time and the backlog, it may take you quickest at least 12 to 24 hours to get your test back. And that usually, if it's positive, is double confirmed by the central lab, and then it gets officially labeled and reported. So there is at least a 7 and sometimes 10 or even 14-day delay between infection itself and then reporting of it, and therefore you could then use a whole series of deconvolution exercises to backwards infer what actually that RT curve looks like if you're interested in the infection event itself. And essentially, if you move from top to bottom, that's what you get. Now, you can get from date of confirmation, date of reporting to date of onset for those who actually show symptoms, that is your symptomatic cases, discounting your asymptomatic cases. Then you can back into using either Thompson's method or Wallinger and Tunis or whichever of these very similar efforts to back into an RT. But again, you have a 7 to 10 day delay. So what we try to do is to use the octopus card, which is like the Oyster card in the UK. And because the octopus card captures 95+% of all public transport by various modes in Hong Kong, that gives us a prima facie case of saying, hey, does that actually give us a good proxy for population mobility, i.e. population mixing? And in Hong Kong, if you just very simply look at the correlation between the public transport statistics as revealed by that octopus card, stratified by age. So basically, we know the age information because they have different fares. So children under 12, students from 12 up till 21 or 23, depending on when they finish university, then adults, and then older folks 65 and over. And the best proxy, if you look at the R.8 here, is the adult transportation. So what you could do is to fit that population mobility proxy into a fairly standard SEIR model. And then what you could do is actually try to nowcast. So the red is actually the estimated RT from empirical observations. And then the blue is what we try to do with the model to nowcast. And that is basically just bringing it up to date. And the octopus data has a 24-hour delay. So essentially, it's real-time, the really real-time estimate of nowcasting. And then the green is actually forecasting. It's basically just saying, if things go and stay stationary, what would it look like? And we use the so-called second wave, the March wave of Hong Kong, to test out whether this actually might work. And indeed, if you actually have all the data and then you take slices through time, it actually looks pretty good. It actually looks pretty good, as you can see here. And so this is on our dashboard, and this is what we used. This is the March second wave. The first wave you can hardly see on this scale. So this is the first, this is the second wave, and this is the third big wave, and this is from yesterday's download. And what we could do, and what we indeed did, was to look at the octopus data, the July octopus data, and of course the dips are the weekends, except you see two dips here. One is the typhoon, and that's why nobody went out. And we used this octopus data, and then we fitted it and looked at what the RT actually looked like. And then you can see that it actually worked pretty well, with the exception of probably this deficit, and therefore a little bit of this deficit. And ultimately, it's basically through these steps, trying to predict what is going to be the total number of reported cases on a daily basis. And that would actually help government sort of see when they might be able to lift as opposed to layering on more of the suppressed interventions. Finally, just let me say that in co-producing policies using epidemiology and using science, it's never trivial. And I often remind myself and other colleagues that we care more about health protection than most other people, because that's our line of work, our line of business. And by that, we think about the RT, we think about hospital planning and surge capacity, whether the health system is going to implode, we think about clinical outcomes, we think about deaths. But there are actually a perennial three-way tug-of-war through the pandemic, because economic preservation in terms of GDP and employment are increasingly important considerations, looking at what COVID has already done in terms of economic damage and what it may likely do come the next 6 to 12 months before a safe and effective vaccine becomes widely accessible to the majority of the world's population. And the third way in this three-way tug-of-war is social consent and emotional well-being. What do I mean by that? We've seen from very early days in the State House of Michigan in the US, sort of gun-carrying protesters basically saying, give me freedom or give me death. And that basically doesn't chime very well with any degree of lockdown and any kind of NPIs, including wearing a face mask and physical distancing. We just saw a very large rally in Berlin over the weekend to the same effect. And so how does one make sure that whatever suppress or NPIs or behavioral interventions governments or the authorities think that it's necessary, backed up by science, how that is actually taken up by people, including, of course, the anti-vaxxers lobby in terms of vaccine uptake, even if a vaccine or a set of vaccine candidates do indeed become available in the next 6 to 12 months. So I think this three-way tug-of-war is something that scientists and epidemiologists would be well served by bearing in mind all the time and trying to understand the difficulties of these different trade-offs and tensions. Thank you very much indeed.
Thank you so much, Gabriel. There have been quite a few questions rolling in from the audience. Thanks very much for everybody who has sent in questions. There are a couple of interesting questions about serology tests and also asymptomatic infection, but what I'm going to suggest is maybe we could come back to that when we throw the floor open, because I think these are quite broad. Again, thank Gabriel. I really enjoyed hearing also especially about the very exciting recent work on public transit and potential interactions with transmissions. So it's really exciting to see that when it comes out. In terms of the questions we've had from participants, we've had one relating to the 2003 SARS epidemic. I mean, obviously that was perhaps at a slightly different time, coming a little bit after the timing of the Chinese New Year. But if pressed, could you, what would be the single most standout aspect that's common with the current pandemic, and what would be the single aspect that seems most different to you with the current pandemic?
I think the single most similar feature is that they are both zoonotic infections. And while we are not absolutely certain of the origins of the SARS-CoV-2, we know that the Chinese horseshoe bat, and then likely via game meat like civet cats, and then jumping into humans, was responsible for SARS-1. Now, SARS-2, hopefully, with the ongoing WHO mission, we might get to the bottom of it, but we may not. I don't know. So I think the zoonosis itself is the most striking similarity, but everything else, basically, SARS-1 and SARS-2, bear very, very little resemblance to each other. They are completely different diseases. They have very different transmission dynamics. They have very different features and therefore require different interventions. We were very, very lucky with SARS-1 in that basically it doesn't transmit until about a week after symptom onset and immediately with the spike of high fevers. So it gives you much more time to actually do contact tracing and then do isolation and quarantine. Whereas this, in another earlier piece of work from our group, we were able to show that actually this probably has a peak shedding and therefore transmission at the time of symptom onset. Possibly actually also with pre-symptomatic transmission up to 3 days before symptom onset, and probably by day 8 to 10, it just is not infectious anymore. And so I think that it's very different. And that's why we're seeing SARS-2 as this major pandemic, whereas SARS-1 was limited to a handful of countries and 8,000 cases worldwide.
Great, thank you. And finally, a question from Ben C. from Hong Kong. Thank you, Ben, for the question, which is that Hong Kong has begun a universal COVID-19 testing program when the number starts to go down to low levels, and there have been reservations that it's not effective and could be misused for surveillance. So Ben asks what your personal opinions are about such a program and whether you'd suggest to reiterate it for the fourth wave in Hong Kong and in other countries.
Well, I think that I think the major value that I see in the universal testing program is actually breaking the logjam and the bottleneck in Hong Kong's testing capacity. Hong Kong has struggled with testing capacity really from the middle of our sort of second wave onwards. So we did very well in ramping up. Everything went very smoothly, but because of the very low numbers of the first wave, we really never needed to ramp up the testing capacity. And the second wave of Hong Kong, which is the March wave, showed how inadequate our testing infrastructure were. And Hong Kong had not been able to actually achieve the breakthrough in terms of ramping up non-public sector participation to the extent that it's very slow in terms of the ramp up, and it's very expensive because it's a volume driven issue, isn't it? So now Hong Kong, I think, has finally overcome that bottleneck, and essentially you've completely removed the rate limiting step of testing capacity with this universal program. Now, one can argue perhaps it would have been better to have done this at the peak of the third wave, which would have been the third week of July, as opposed to now when you are simply trying to mop up remaining chains of transmission. Now, mind you, if you actually believe in some of the estimates that we have done ourselves very recently, literally a few days ago, we are probably still seeing somewhere around 100 transmission chains out there that are potentially infectious, that would actually give rise to a secondary. Now, you could then argue, well, maybe it would still fade away by itself, maybe. But if you actually had paid attention to the RT curve that I showed you, compared to the second wave, it's taking an awfully long time to come down. And it's now plateauing at about 0.4, 0.5, and it has been there for the last 5 days. So eventually, so long as we don't have a flare-up, it will fade away, but it's taking a very long time. So I think that, you know, it might, as Ben C said, it might actually be a dry run of the potential much larger autumn-winter fourth wave, especially with seasonal forcing. And I think seasonal forcing shouldn't be underestimated, learning now from the example recently of Auckland and Melbourne. Both places had done incredibly well up till the Southern Hemisphere winter. If it could happen in those places, it surely could happen in Hong Kong again. And I think, yes, it might be something that one might consider with the coming fourth wave.
Fantastic. Thank you very much, Gabriel, for those important insights. And I think also perhaps some important lessons for countries in the Northern Hemisphere going into their flu season fairly soon as well. But we'll look forward to having you back on once we throw the floor open. But